Those are cases for pediatric education. I'd be happy to do one every now and then. Let's start by case one, status asthmaticus, deconstructing the acute exacerbation. Stepwise management, severe obstruction recognition, and clinical pathways in pediatric emergency care. 14-year-old adolescent presents with 2-day history of worsening asthma symptoms. Patient profile, albuterol overuse, one full inhaler over the past week, two past month, 4 to 8 puffs per dose. Controller meds, non-compliant for several months by not renewing her inhalers. Temperature febrile. Vitals and telemetry heart rate 135 beats per minute. She's tachycardic, respiratory rate 42 breath per minute, and blood pressure 130 over 70, will SpO2 92% on room air, which is hypoxic. The exam highlights short clipped phrases, intercostal neck muscle retractions, diminished breath sounds, prolonged expiration, inspiration to expiration 1 to 3, biphasic wheezing, and distant heart sounds. Patient remains refractory after aggressive first-line therapy. In first-hour intervention, nebulized albuterol 2.5 milligrams times 3 times, nebulized ipratropium 0.5 times 3 times, oral prednisone 60 milligram once. Reevaluation after 1 hour max. Saturation 92% on 2 liter per minute oxygen via nasal cannula. Exam unchanged severe obstruction, will the status subjectively more comfortable but objectively failing. Assessing the best next step in management given the refractory presentation and high risk of respiratory failure. What is the best next management steps? A, administer magnesium sulfate intravenously. B, begin an intravenous infusion of terbutaline. C, give an additional dose of prednisone 60 milligrams orally, or prepare for rapid intubation and ventilator management. The right answer would be intravenous magnesium sulfate. Irrational, the patient has severe airway obstruction and is failing bronchodilators. The IV magnesium is the evidence-based second-line adjunct before pediatric ICU level intervention. El cortical data 12 to 19 magnesium sulfate 62 grams per liter. Intravenous terbutaline continuous infusion require PICU monitor. This is premature for emergency department management. To adrenergic agonist toxicity, signs include tachycardia, tremors, and decreased diastolic blood pressure. Additional prednisone, systemic corticosteroids are already on board, and take hours to peak. Redosing immediately adds no acute benefit. Rapid intubation, this is an absolute last resort. Non-invasive support and second-line pharmacologics must be tried first. Physical exam findings map direct to severity of airway obstruction. Moderate obstruction, expiratory wheeze. Severe obstruction, our patient biphasic wheezing, inspiratory or increasing prolonged expiration, inspiratory to expiratory phase 1 to 3, progressive use of accessory muscles. Critical impending failure, the quiet chest, critical lack of airway, severe respiratory fatigue. Two primary vitals signs predict the need for hospitalization. And oxygenation will mechanics, oxygenation is saturation less than 94 at emergency department presentation. Our patient is 92. Where a predictor of inspiratory to expiratory ratio more than 1 to 1, patient presents with 1 to 3 severe prolonged expiration. The combination of these two metrics at presentation is the most heavily weighed predictor for inpatient admission. First-line emergency department management, bronchodilation, albuterol and ipratropium, where inflammation control, systemic steroids, oxygenation goal, provide supplemental oxygen to keep saturation above 90. Corticosteroid selection, dexamethasone outperforms prednisone on compliance. Dexamethasone, 2-dose course, second dose dispensed at ED discharge. Higher competition rate, lower overall cost equal to prednisone. Prednisone 2 milligram per kilogram, maximum 60. It's a 5-day course. Lower completion rate once patient is home, generally higher overall burden, with efficacy equal to dexamethasone. Second line intervention for refractory frequent aerosol albuterol, 4 to 8 puffs delivered frequently, intravenous adjunct, IV magnesium sulfate 50 milligram per kilogram, normal saline bolus. Magnesium sulfate act as an adjunctive bronchodilator. Study shows it improves symptoms, but does not necessarily decrease the ultimate need for hospitalization. Step 3, which is pediatric ICU management protocol, continuous nebulization, systemic beta agonist زي التربيتالين, non-invasive support, trial of non-invasive positive pressure ventilation, CPAP or BiPAP on Heliox 70 to 30 before considering intubation. Try to decrease the intubation as much as you can. Last resort measures for impending respiratory failure, dissociative bronchodilation, intravenous ketamine, with definitive airway intubation and mechanical ventilation. Intubation and status asthmaticus carries a high risk of barotrauma and hemodynamic collapse. It should only be performed when PICU level non-invasive fail. High dose adrenergic agonists carry significant risk of toxicity, like neurologic tremors, cardiovascular tachycardia, metabolic hyperglycemia, and electrolyte decrease in serum potassium, magnesium, and phosphorus level. Sensitized clinical pathway for status asthmaticus at presentation hypoxia, first line albuterol and ipratropium, and dexamethasone or prednisolone. Refractory, second line magnesium sulfate, impending failure, third line continuous albuterol and IV terbutaline, non-invasive positive pressure ventilation. Last resort would be intubation. Core clinical pearls for status asthmaticus: saturation less than 94, IE ratio more than 1 to 1 are the most reliable objective predictors of the need for inpatient admission. Intravenous magnesium sulfate is the critical bridging therapy between basic emergency department management and pediatric ICU level continuous infusion. Aggressive escalation demands aggressive monitoring. Hypokalemia, hypomagnesemia, and tachycardia when running continuous adrenergic agonist. Thank you. كلام جميل.